Thanks for your kind invitation, kind introduction. So the topic of my talk today will be about translational medicine and how in pulmonary hypertension did we manage to understand the mechanisms of the disease and develop drugs to treat this disease. As you said, I work in Paris at the University Paris-Saclay, which is a very large university, and I work for the French National Institute of Health, which is named INSERM. I also organize networks for pulmonary hypertension at European level and also at national level. And it is very important for us to share our knowledge because we all know that pulmonary hypertension is complex. It has many causes, and some causes are treatable. So that's extremely important to share. I have some disclosures which are listed on that slide. And I will start by a short history of time. And we have been around in the last 70 years with pulmonary hypertension as a growing field in cardiology, in pulmonology, in internal medicine, and also in basic science. And in 1960, the WHO organized, the World Health Organization organized a meeting, an expert committee in Geneva. It was about chronic cor pulmonale, meaning chronic right heart failure due to chronic lung diseases. And 13 years later, WHO organized another meeting about primary pulmonary hypertension. And at those meetings, there were very limited attendance, and the people were very famous, Nobel Prize winners, and very important people working in the field of pulmonary hypertension. And the trigger for the second World Health Organization meeting was the appetite suppressant induced pulmonary hypertension outbreak in Switzerland, Austria, and Germany, so in Europe. After this meeting, there were 25 years before the third World Symposium meeting, which took place in Evian. And Evian, it's very close to Geneva. It is in France, on the other side of the lake. There is a lake between France and Switzerland. On one side, you have Geneva with WHO, and on the other side, you have Evian, which is a very nice place, you know, the water. And this meeting was endorsed by WHO, but it was organized by a panel of experts in the field. And since 1998, every 5 years, we organize a meeting, once in Venice, once in Dana Point in the US, once in Nice, the second time in Nice, and last time in Barcelona. And what is very important is that each time we have a meeting, we try to publish the information which has been generated by the meetings. And we have task forces, we have chairs, we have panels, and each of the symposia since 2003 have been published in major journals. In 2003, 2008, and 2013, it has been published in the Journal of the American College of Cardiology, and the Nice one, the second one, and the Barcelona one were published in the European Respiratory Journal. The very first time there was a dedicated chapter on cellular and molecular pathobiology of pulmonary arterial hypertension was in 2003. I was much younger, but I was leading that task force. And this paper, which has been published in JACC, has been cited almost 2,000 times. So really a very highly cited paper, meaning that the people were ready to read more about mechanisms of pulmonary hypertension, and more importantly, on group 1, pulmonary arterial hypertension. And in that chapter, there were many very important slides. This one has been published after in the New England Journal of Medicine with a much better layout, but it was the very famous 3 pathway cartoon in which we were showing that there were treatable pathways in pulmonary arterial hypertension, and that these treatable pathways could be targeted with endothelin receptor antagonist, PDE5 inhibitor at that time, or guanylate cyclase stimulator later on, and prostacyclin derivatives, and prostacyclin receptor agonists later on. So you see here that based on this very simple cartoon, there was a lot of prerequisite to generate such a simplified cartoon explaining what is disturbed and treatable in PH. But there were also other disturbed pathways which are not treatable right now. This was, for example, the serotonin pathway, and also everything around the potassium channels, the elastase, the cytokines, chemokines, and the disturbed genetic abnormalities which were discovered in 2000 and which affected the BMPR2. And this was, at that time, very novel science. So there were many pathobiological factors which could be targeted, but at that time, only 3 were targetable. In fact, when you look at the 6th World Symposium on Pulmonary Hypertension and the paper we published in 2019, the main thing which was described as abnormal in PAH was an impaired endothelial-dependent vasodilatation. Of course, there were many other problems leading to remodeling, but what was targetable was vasodilatation and vasoconstriction. And of course, prostacyclin, nitric oxide, endothelin were the most prominent factors affected by the disease PAH. And this did not come from nowhere. It came from the bench to the bedside. And you see the prostacyclin pathway. Here you have Sir John Vane. Sir John Vane was a British professor, and he was awarded the Nobel Prize of Medicine and Physiology for the discovery of prostacyclin. And these 3 gentlemen were awarded the Nobel Prize in Physiology or Medicine in 1998 for their discoveries concerning nitric oxide as a signaling molecule in the cardiovascular system. And Masashi Yanagisawa from Kobe in Japan described endothelin 1 and was awarded many important prizes for that discovery. And these 3 pathways, within years, led to major randomized control trial, such as the randomized control trial of prostacyclin, the randomized control trial of sildenafil, and the randomized control trial of bosentan. And based on the basic science discoveries, there were lots of very important randomized control trials, which led to the approval of drugs to treat pulmonary arterial hypertension. And here you recognize the very famous chapter published in the New England Journal of Medicine, which is derived from the paper in the JACC in 2004 as well. And here you see 10 years later, the same pathways with more targets, but only 3 pathways were targetable. So very important thing is that drugs are developed because biology is better understood. In 2004, in our JACC paper, the potential role of the TGF-beta superfamily in vascular remodeling was clearly described. And in this cartoon, you can see that TGF-beta, but also activins, BMPs, and GDF were described as putative targets for future drug development. And it's very nice because 20 years later, we had the approval of a drug which is an activin signaling inhibitor. And this is a story I'm going to tell you today. So in 2024, we were at the 7th World Symposium on Pulmonary Hypertension. You see I'm here. Christophe Guignabert, my colleague, is here. Peter Dorfmüller, Marlene Rabinovich, Sébastien Bonnet, Kurt Stenmark, Andrea Olszewski, Sonny Pulmasetti, Jürgen Amann, and Ralph Shamuli, so you know everybody now, And we were in charge of the pathology and pathobiology of pulmonary hypertension. You see, 20 years later. And 20 years later, we focus more on pulmonary vascular remodeling and BMP activin signaling. So clearly, what we described in 2004 was very, very crude. It was just an hypothesis derived from the BMPR2 disturbances and the understanding that remodeling was important. But in 2024, based on recent article we have published with Christophe Guignabert and others, we have been able to show that this remodeled vessel with enlarged media, fibrotic intima, multi-layer intima, and here it's adventitia, of course, we have been able to identify what is disturbed. And what is disturbed, it's the pulmonary vascular homeostasis. In a normal, healthy vessel, you have a well-balanced signaling through the TGF-beta activin nodal branch and through the BMP-GDF branch. And if you want to understand that in a very simple fashion, what is driven by TGF-beta is pro-remodeling. What is driven by BMP and GDF is anti-remodeling. And in fact, in a normal, healthy vessel, you have a well-balanced trigger through TGF-beta activin and BMP-GDF. In PH, we know that there is a mutation in many patients in BMPR2, and we know also in the absence of mutation, there are many disturbances of this pathway, which is down-regulated, and this pathway, which is over-regulated. And in fact, there is too much activin trigger, and there is not enough BMP trigger. And this leads to an abnormal targeting of the SMAD2/3 phosphorylation, leading to pulmonary vascular remodeling. So in fact, in 2024, in our summary of the pathobiology, we really insisted that the BMPR2 and the TGF-beta superfamily signaling are critical in maintaining normal pulmonary vascular homeostasis. And here you see that pulmonary vascular homeostasis requires similar balanced SMAD158 and SMAD2/3 signaling. And you see everything is well balanced. It is complex, but it is well balanced. And in the setting of, for example, a BMPR2 mutation or an activin overregulation, you will have a decreased SMAD158 or an increased SMAD2/3. So it will lead to proliferation. And that's very important to understand because many factors which are believed to be important in pulmonary arterial hypertension are involved in that pathway. For example, when you have a mutation in BMPR2, obviously, it decreases the anti-proliferative branch. When you have increased pro-inflammatory cytokines, it will downregulate BMPR2. And when you have such a status, you also have excess production of activin, which will stimulate the activin receptor 2A and 2B. So this is a very simplified understanding of what's going on in pulmonary arterial hypertension. And here you see that a summary slide of a paper we published 2 years ago in the Lancet Respiratory Medicine. If you consider that TGF-beta BMP is very important in pulmonary vascular remodeling, you may need to target the TGF-beta pathway in order to restore pulmonary vascular remodeling. And you can block the TGF-beta activin nodal branch, for example, with neutralizing antibodies or with ligand traps or with inhibitors or with antisense. And you can stimulate the defective pathway through recombinant proteins activators or gene therapy. And the idea is to block pulmonary vascular remodeling and try to reverse remodel. And the most advanced drug for the treatment of pulmonary arterial hypertension is a biologic. It is called sotatercept. It is a fusion protein. You see, it's here for sotatercept. Donc it looks like an immunoglobulin. You have the immunoglobulin IgG1 fragment, Fc fragment, and you bind it to the extracellular domain of activin receptor type 2A. So it will act as a ligand trap. It will trap, you see here the little sotatercept traps the excess activin, which is involved in increased pulmonary vascular proliferation. And with this treatment, you can hypothesize that a treatment like that could work as a reverse remodeling agent through a rebalancing of anti-proliferative and pro-proliferative signaling pathway. You will decrease the excess activin stimulation and restore the defective BNP stimulus. Here you see the preclinical paper, which was published by Paul Yu's team with Lei Ming Young in Boston at Harvard Medical School. And you see when you have defective pulmonary vascular remodeling, you can try to block the excess activin with sotatercept or a sotatercept-like agent in mice and rats. And in preclinical studies, sotatercept improved hemodynamics, right heart hypertrophy, right heart function, and pulmonary arterial remodeling. But what is really important is that we were able, exactly at the same time, to develop a randomized controlled trial, which was a very important randomized controlled trial because it was a phase 2 study, which was rather short, 24 weeks, but with patients who were treated with, parenteral prostacyclin for 37% of them, and more than half of them on triple combination therapy. So what is important to understand is that the patients we recruited in that study, they were already on pronounced pre-treatment. They were, for many of them, on maximum combination therapy. And you see that after 6 months, the primary endpoint was reduction in pulmonary vascular resistance. And you see that the reduction in pulmonary vascular resistance was 20% on sotatercept 0.3 milligram per kilogram given subcutaneously every 3 weeks. And it was 34% at 0.7 milligram per kilogram every 21 days, 3 weeks. So this is a biologic. It is given by subcutaneous route every 3 weeks, and it gives you dose-dependent reduction in pulmonary vascular resistance. On top of that, it increased the walk distance, it decreased NT-proBNP, and it improved functional class. The sotatercept was well tolerated. There was some thrombocytopenia and increased hemoglobin. You need to know that this is a repurposed drug, which was initially developed for myelodysplastic disorders with refractory anemia. So it's not a big surprise to see that the patients increased their hemoglobin, and some of them had thrombocytopenia. Over time, we discovered other side effects, including telangiectasia and bleeding, mostly nasal bleeding. So the patients have a phenotype which looks like Randu-Osler-Weber disease, you know, the hemorrhagic hereditary telangiectasia. So the patients on sotatercept improve their hemodynamics, improve their walk distance, improve their BNP, and their side effects of increased hemoglobin, decreased platelet, telangiectasia, and nasal bleeding. Based on that, we launched a family of phase 3 trials, and the 3 phase 3 trials are Stellar, Zenith, and Hyperion. Stellar is a pivotal study, which is a study testing sotatercept on top of stable background therapy with a primary endpoint of 6-minute walk distance. It is a pivotal study designed to lead to the approval of the drug by FDA and European agency. Zenit was a study in patients on stable maximum background therapy who remain in functional class 3 or 4 with a high risk of death. And here the primary endpoint was time to first event of all-cause death, lung transplant, or PH-related hospitalization. And Hyperion, so these 2 papers have been published in the New England Journal of Medicine. And the 3rd paper is not published yet, but we know the positive results already. And the results will be presented in detail at the next European Respiratory Society meeting in September in Amsterdam. And here you see these are patients with a new diagnosis of PH who are on stable double combination background therapy, but these patients are not yet doing well enough, and they are randomized to receive sotatercept or placebo, and time to clinical worsening is a primary endpoint. So let's start with the phase 3 trial STELLAR, which was published 2 years ago in the New England Journal of Medicine. And you see the primary endpoint was very clear with a 40-meter improvement on sotatercept versus baseline as compared to placebo. And this is a very, very important result leading to the approval of sotatercept in America, North America, and in Europe. You see there was a series of secondary endpoints, and most of the secondary endpoints were positive, as you can see here, PVR, NT-proBNP, functional class, time to clinical worsening, and 2 out of 3 quality of life questionnaires, pH impact. And on top of that, I have added a square showing that the main driver of decrease in pulmonary vascular resistance was a decrease in mean pulmonary artery pressure, but not a decrease in an increase in cardiac output. So the main driver of the reduction in PVR is a reduction in pressure. There was also improved time to clinical worsening. You see here the time to clinical worsening was improved by 84% on sotatercept versus placebo, and the safety found the same results, mostly bleeding, telangiectasia, increased hemoglobin, and thrombocytopenia. And the most important bleeding cause was nasal bleeding, epistaxis. So that was a very important study. And 3 months ago, we presented the next phase 3 trial in Chicago at the American College of Cardiology. It was my privilege to present these results in Chicago. And it was a very important study, I must say, on patients with pulmonary arterial hypertension at high risk for death. And in this study, the patients had to be in functional class 3 or 4 at high risk for mortality. This was identified by a risk score, the REVEAL Light 2 score, which was of 9 or more. And we randomized the patients to placebo or sotatercept, randomization stratification based on REVEAL score and pH subtype, connective tissue disease or no connective tissue disease. The primary endpoint was time to first event of all-cause death, lung transplantation, or pH worsening related hospitalization. And there was a pre-specified interim analysis after 59 events of the primary endpoint, because if there was excess mortality or decreased mortality, we did not want to wait for too long to read the results. So after 59 events, the independent data monitoring committee could say, stop the study because it is efficacious, stop the study because it is not efficacious, or keep on moving until the final analysis because we need more data. And in fact, at the interim analysis, this is what happened. This is at the time of around 60 events. You see it was in July 2024, so it was exactly 1 year ago. 155 patients had been randomized for at least 24 weeks. And you see that in the sotatercept group, 12 discontinued early. On placebo, 18 discontinued early, 10 because of death, and here 5 because of death. And when you look at what we consider as completion of the study, the patients are considered to have completed the study if they experience an event of pH worsening related hospitalization or lung transplantation. And here you see it's very, very different because 30 patients completed the study on placebo and only 4 on sotatercept. So when you compare placebo with sotatercept, 70 were ongoing on sotatercept, only 38 on placebo. So that's what we call the attrition on placebo because the patients were so severe that they either die or have an event which leads to interruption of the study. And you can see here at the top right, on sotatercept, the median follow-up of patients was around 10.6 months and only 7 months on placebo because the patient did not remain in the study because they either die or were completers of the study. And these are the characteristics of the patients, extremely severe patients. You see 1/4 in functional class 4, 3/4 functional class 3, really light 11 or more, 30%, more than half on prostacyclin infusion, almost 70% on triple combination therapy, walk distance 270 meters despite maximum therapy in young patients, NT-proBNP around 3,000, PVR around 10 Wood units, mean PAP around 50, and cardiac output around 4.5. And you see this is the primary endpoint. Sotatercept significantly reduced the relative risk of morbidity mortality by 76%. And based on that, the study was terminated because of efficacy. You see the p-value was less than 0.0001. When you look at the components of the primary endpoint, there were 7 deaths on sotatercept, 13 on placebo, 1 lung transplantation versus 6 on placebo, 8 hospitalization versus 43 on placebo. So you see there is a big, big difference with this p-value. When you look at the subgroup analysis, well, the patients benefited from the study drug in all subgroups, across all subgroups. Obviously, when you are older, but there are not many patients, the magnitude of effect is a bit less pronounced, but it is still the right direction. When you look at the other endpoints, because the study was stopped early, the secondary endpoint did not meet significance because the p-value is no longer 0.005 because the study was stopped early. The p-value to be significant needed to be 0.0021. So the bar was very high, but we did not want to maintain patients on placebo after the results. So you see, overall survival was improved by 58% with a p-value of 0.03, which is not significant, but which shows you a right direction. Transplant-free survival was improved by 66%. NT-proBNP decreased by 2,000 and more. Mean PAP decreased by 20. PVR decreased by 4 Wood units. Improved functional class in 56% versus 28% on placebo, and everything went to the right direction. The side effects were mostly bleeding events, which were more common on sotatercept versus placebo, mostly epistaxis. The serious bleedings were slightly more common on sotatercept than placebo, but not that much. There were more cardiac events on placebo, because of pulmonary hypertension progression. Increased hemoglobin was seen on sotatercept. Telangiectasia were seen on sotatercept. And very important interim summary. Zenith is the first PAH study designed to assess major morbidity mortality events, and it is the first to be stopped early at a pre-specified interim analysis for efficacy. And following the Zenith results, there was a loss of clinical equipoise for further placebo-controlled investigation of sotatercept in PAH in patients with a high risk of death, and there were patients with such findings in Hyperion. So Hyperion was discontinued, and the results of Hyperion have been announced in a press release a few months ago, and they will be presented in Amsterdam in September. Other drugs target the activin signaling pathway, and you see this drug named cibotercept. It's a novel, modified, investigational activin receptor type 2B ligand trap. So it's not 2A, it's 2B. It should be better in terms of bone marrow effect. According to the manufacturer, the hemoglobin elevation should be less pronounced, and the telangiectasia should be less pronounced because it allows anti-proliferative BMP signaling thanks to a BMP binding spare. It was hypothesized that this drug would minimize the safety signal. And here you see the study design. It looks like Pulsar, the phase 2 of sotatercept. And you see 3 doses were tested as compared to placebo. And the enrollment was completed 9 months ago in September 2024. But there were problems in that study because Keros, the manufacturer, announced early termination of the Tropos trial. First, in December, they announced that they stopped the 2 highest doses because of the observation of pericardial effusions at those levels. And then in January 15, they stopped also the lowest dose because the safety review found new observations of pericardial effusion. So there is here a signal on the pericardium, and this will be very important to identify in all activin signaling pathway inhibitors. So as compared to the start of my talk, we now, in the current therapies, have 1, 2, 3, 4 pathways to target. Nitric oxide remains, endothelin-1 remains, prostacyclin remains, but now we have the TGF-beta pathway with, at the present time, a single drug, sotatercept, which is an activin signaling inhibitor. But of course, other targets can be explored, and you all know that PDGF, platelet-derived growth factor, is important in the pulmonary vasculature. It is expressed in pulmonary arterial hypertension lines. This is a paper by Frédéric Perrault from my lab, and Frédéric found that there is an increased PDGF expression and PDGF receptor expression, and that PDGF-induced proliferation can be blocked by PDGF tyrosine kinase inhibitor, such as imatinib. So imatinib, it's a selective tyrosine kinase inhibitor. It blocks, of course, c-KIT. It blocks also PDGF receptor, and it blocks ABL, the pathway involved in chronic myelogenous leukemia. And here you see that this pathway has been targeted in the IMPRESS trial, which was a phase 3 study. In the phase 3 study, the patients improved their walk distance, but they had more clinical worsening on imatinib as compared to placebo. And in fact, there were bleeding events, and there was a poor tolerance of this agent in patients with PAH. So the patients with PAH who were treated with oral imatinib were withdrawn from the studies. After that, there was a phase 2-3 study of inhaled imatinib, which was also terminated early because of lack of efficacy. And currently, there is a study ongoing with a modified imatinib, which should be better tolerated. So we can discuss that later on. But clearly, there is another drug, seralutinib, which is a small molecule PDGF receptor inhibitor, which has been developed for pulmonary arterial hypertension. And you know that there was a positive phase 2 study, namely TORREY, and there is an ongoing phase 3 study, namely PROSERA, of inhaled seralutinib. The phase 2 was positive in terms of PVR, with a 15% reduction in PVR, and the ongoing phase 3 study will consider walk distance as the primary endpoint in order to be approved if positive. So in that final slide, I will spend a couple of minutes to guide you through the new directions for future research. So here you have a normal vessel, and here you have a remodeled vessel. Here you have different pathways which have been tested in randomized controlled trials, or which have been considered for randomized controlled trials. So we just discussed the light blue box and the green box. And here, the blue box, you see therapies targeting the BMP TGF-beta pathway. Here you have activins, which can be blocked by ligand traps. And this is where sotatercept lies, with an approval for PH as an add-on therapy. But you have also other targets, such as BMP9 or such as other GDF, which could be considered for drug development. You have also FK506, which could rebalance the BMPR2 pathway, and which has been tested in phase 2 studies, but with no positive phase 3 study to date. So the TGF-beta superfamily is extremely interesting. It is a new area for research with one currently approved therapy, but with significant side effects in terms of nasal bleeding, hemoglobin increase, telangiectasia, and recently described some pericardial effusions and some hypoxemia due to pulmonary capillary dilatation on sotatercept. But altogether, the safety efficacy balance remains very positive for sotatercept to date, and there are thousands of patients treated in America and hundreds in Europe. The PDGF pathway, I just told you that imatinib has been terminated, both by oral and inhaled route, that there is a new oral imatinib compound currently investigated, and there is an inhaled tyrosine kinase inhibitor currently tested in phase 3, which should maybe be presented early next year. The anti-inflammatory agents are very important to study, but all the studies to date on IL-6 antibodies, IL-6 receptor antibodies, anti-CD20 antibodies have been negative to date, with some subgroups with positive effect. But right now, the IL-6 CD20 approach is still investigational. And then you have a list here of targets which should be considered for the future: the hormonal pathway, the metabolic pathway, the epigenetic alterations, the sympathetic nervous system with pulmonary artery denervation, the extracellular matrix, and cell-based therapies. So with that final slide, I thank you very much for your kind invitation. I wish you a good day in Medellin, And I will stop sharing my slide in order to see you on the screen.
Okay, doctor, thank you very much for your excellent presentation. I have some issues, and I think I find it fascinating all this journey for understanding the pathobiology of the disease and how until recently we only provide treatments for the patients with the objective of affect the hemodynamic of the disease. But with this new drug, the sotatercept, we now have more opportunities to provide a direct treatment that affect the pathogenesis of the disease. So say that, what do you think about do this medication to other forms of hypertension that um, make the vascular disease, the vascular remodeling to produce. I mean, for example, people with group 1 pulmonary hypertension, but for congenital heart disease, because the effect of this disease is to increase the vascular remodeling. What do you think about that?
Thank you very much. So it's a great comment. Let's start with the classification of pulmonary hypertension. So you are all aware of it, but you have the group 1. And indeed, with sotatercept, we only tested the idiopathic, familial, congenital heart disease, but which have been closed. So 1 year or more after closure. We never tested Eisenmenger syndrome, for example. We tested also drug-induced pulmonary arterial hypertension and scleroderma and connective tissue disease. So we never tested congenital heart disease, which has not been repaired. It could be interesting, but there are two limitations. The first one is hemoglobin level, because you saw that sotatercept increases hemoglobin level. And if you have patients with already 18, 19, 20 grams per deciliter, you will increase even more with sotatercept. The second thing is risk of bleeding. And the risk of bleeding is increased in congenital heart disease. You have some people spitting blood, and this should be also evaluated. But I'm sure that doctors in America, because they have access to the drug, I'm sure they're already testing the drug, and there will be investigator-initiated study. Then I can develop a little bit more. In group 1, you have pulmonary veno-occlusive disease. It's a very specific form with alterations of the small veins. And usually when you give them drugs for PH, they develop pulmonary edema and they die. So we have to transplant them. And by chance, a patient with PVOD was included in PULSAR because he was labeled as PAH, but we were doing genetic screening. So we discovered that one of the patients had homozygous mutations in EAF2-AK4. So this patient had PVOD, and this patient improved. So maybe for PVOD, there will be some possibilities, but we need more than one case to say that. And then in the classification, you have the major form of pulmonary hypertension, and most of you are cardiologists. So it's group 2 pulmonary hypertension, post-capillary pulmonary hypertension. And there is currently a study named Cadence. Cadence, it's a randomized control trial for for PH group 2, post-capillary, but with combined post and pre-capillary pulmonary hypertension with pulmonary vascular resistance above 4. So the study is ongoing. It has not been terminated. And I think the results should be presented next year. So that will be interesting. And then you have the group 3, people with lung disease, the group 4, people with CTEPH, but there is no study right now in group 3 and group 4.
Okay, doctor, thank you. So I think we will wait these results of this trial. Dr. Edison Munoz, who is a professor of our department, have a question. When do you expect sotatercept to be available in Latin America, and with its cost effectiveness?
Yeah, no, it's a great question. I was in Brazil, and I saw that sotatercept was launched in Brazil end of May. So there, of course, there is a company. It's Merck. I don't know if in Latin America it's Merck or MSD. Maybe it's MSD in Latin America,
I
like
think
in
that.
yeah. So there were some people from Colombia, and I think the lady in charge of the drug in Latin America is from Colombia. So I don't know her name, but I'm sure your professor will find very easily. So the lady working for Merck in Latin America is Latin American from Colombia. And I told her that they were very group. She knows you. And I'm sure there is a plan to have your countries covered. And with, of course, in my country, we have it, but we cannot treat everybody because it's very expensive. And I will go to the second question. But if you have patients who really are good candidates, it's good to have the drug available. Then cost effectiveness, it's always the same thing. It depends what you measure, what you don't measure. In Zenit, what is very important is that there is improved very hard endpoint. So in patients with advanced disease, it seems to be cost effective because you improve outcomes such as hospitalization, transplantation, mortality, and that costs a lot. If you treat early disease, it is more difficult to say it is cost effective, but you improve time to clinical worsening. So I'm sure the company is developing cost effectiveness studies, and these cost effectiveness studies will tell us what it means. So it's a great question, and I hope you will find the name of the lady. She's a medical doctor, and she works. She's from Colombia.
Okay, doctor, thank you. We will try to find out that information. Dr. Leah Mulet has a question. She is a cardiology fellow of the program.
Thank you so much. Good morning, Professor. Thank you for accepting our invitation, and thank you for your excellent conference. I have two questions. The first one is regarding, do you think these therapies would be first-line therapy? I mean, like changing our practice in pulmonary arterial hypertension. And the second one, it was regarding group 2 that you comment earlier about this trial that is ongoing. Those are the majority of patients we see as cardiologists with pulmonary hypertension that has left heart disease and remodeling of the vasculature of the pulmonary vasculature. So frequently we are confronted to these patients, and we have to shut it down to considering for left ventricular assistance device or heart transplantations because of pulmonary hypertension. What are your approach regarding these kind of patients? Thank you so much.
Thank you very much. It's a very important question. So the group 2 pulmonary hypertension with combined post and pre capillary pulmonary hypertension with PVR above 4, they are not that common. Now we agree together that PH due to left heart disease is very common, but usually it's only post capillary pulmonary hypertension with very, very limited elevation in PVR. But when they have very high elevation in PVR, we know that they have remodeling of both the precapillary pulmonary hypertension, but also the post-capillary vessels, precapillary vessels and post-capillary vessels. And that's where the single case of PVOD I described is interesting because the patient improved. And thus, the patients with combined post and pre-capillary, until today, when you treat them with a drug approved for PH, they usually don't do well. Usually, when you look at bosentan or intravenous epoprostenol or even sildenafil, when you look at well-done studies, either in patients with FREF or FPEF, the outcome is not good. So the study cadence tests patients with PVR above 4. And when these patients are treated, the idea is to fight against remodeling. And the study has not been terminated, so that's good news, but we don't know, of course, the results. But when the results will come, it may change practice. And if it changes practice, it will be certainly exactly what you just described. It could be a treatment to help patients to be bridged to heart transplantation, to have heart transplantation only, versus considering very rarely heart and lung transplantation because of very high PVR, or very often because the patients are not eligible for heart transplantation, a treatment to improve outcomes, improve quality of life, etc. Regarding your first question, the sotatercept has never been tested upfront. So all the patients who have been tested with sotatercept were already treated with 1, 2, or 3 drugs, more and more 2 or 3. And when you look at the most recent study, which is not reported yet, but which will be reported very soon, the patients have been diagnosed less than 1 year before study enrollment, while in Pulsar, Stellar, Zenith, they were prevalent patients with a history of PH at least 7 years. So in the new study, we will know if early intervention translates into better outcome. And I'm sure, and we are ready to do that, some people will consider initial combination therapy with 2 drugs or 3 drugs plus sotatercept. I'm aware of cases of patients who could not tolerate prostacyclin and who are doing very poorly, who have been treated very early with sotatercept with some positive outcome. But I don't want to discuss that too much because for me, it's not ready for prime time, but it is something to study indeed.
Okay, doctor. I think that there are no more questions from the audience. I want to thank you again for accepting this invitation, and I hope you have a nice day. See you later.
See you. Bye-bye.
Okay, thank you all.